Bismillahirrahmanirrahim. Today we will talk about two groups of common groups of skin diseases. The group of parasitic infections of the skin. We will talk about scabies and pediculosis. And in the group of allergic skin diseases, we will talk about urticaria and papillary urticaria. A 31-year-old man is complaining of itching, which is worst by night of 3 weeks duration. 2 days ago, his wife also started to scratch her skin, especially during sleep. Can you answer? Here we have a patient complaining of itching, which is worse by night. This is a characteristic data or character of itching of scabies. Also, his wife became infected, and this also suggests scabies, which is one of the highly infectious skin diseases. So the most probable diagnosis is scabies. The answer of the other questions will be seen in the last part of the lecture. So in the group of parasitic skin diseases, we'll talk about scabies and pediculosis. Scabies is a contagious or highly infectious skin disease caused by Sarcoptes scabiei mite. Who is responsible for the infection by scabies is the fertilized female of Sarcoptes scabiei mite. The fertilized female, during laying eggs, it digs tunnels inside the horny layer, which is a very superficial layer of the epidermis, to lay down eggs. So it will form the primary lesion of the disease, which is the bud. The mode of infection: direct infection from infected patient or infected animal, or indirect through the use of infected bed towels and clothes. Incubation period from 2 weeks up to 2 months. The pathognomonic lesion is the burrow. The burrow is seen as a grayish-white ridge of half up to 1.5 centimeter in size, taking S shape or C shape. Unfortunately, burrow is usually not seen in most of cases due to its disturbance by the scratching, the act of scratching due to itching. The patient will complain of severe itching, which is more by night. It is more by night because the movement of the Sarcoptes scabiei mite is stimulated by warmth which occurs to the body surface during sleep. The lesions are polymorphic, non-specific, but the specific is the distribution or the sites of the lesions. This is the distribution of scabitic lesions. First, the lesions are distributed bilaterally and symmetrically. The pathognomonic site is the webs are the webs of fingers. Then the flexor aspects of wrist joint, antecubital fossa, axilla, affection around the umbilicus, medial aspects of thighs and dorsi of feet. We can add in females the areola of the breast, and in males the genitalia of males. The lesions are polymorphic, maybe scratch marks, papular lesions, excoriated papules, maybe eczematous lesions in the breast of females. And in infants, we may see vesicles in palms and soles, vesicles and bulli in palms and sole of infants. This is the barrow. As we see, it takes curved line with one end there is a vesicle. At this site, if we moisten the skin by potassium hydroxide 15% and scrap the lesions and see the scrapped material under microscope, we will see the Sarcoptes scabiei mite and its eggs. Or directly by dermoscope, which is a magnifying apparatus that can be put directly on the skin, we can see the mite and its products inside the barrow. The site here is in the medial aspect of middle finger. This is the scrapped material from barrow when are seen under microscope. This is Sarcoptes scabiei mite. The size of the mite is 0.2 up to 0.4 millimeter in size, and these are the eggs of the mite. Also the mite of Sarcoptes scabiei. Here is the affection of the classic sites by polymorphic lesions. The pathognomonic lesions, as we see, the webs of fingers. In the webs of fingers, we can see scratch lines, crusted lesions, which are due to secondary bacterial infection, impetigo lesion, erythematous arterial papules, and scratch marks. So polymorphic lesions, but in pathognomonic sites, the web of fingers. Also crusted lesions here on the webs of fingers. Also scratch marks. This is Sarcoptes scabiei mite under microscope. These are different forms of barrows, reach of S shape or C shape. The size is half up to 1.5 centimeter in size, and these are not seen frequently in cases of scabies due to disturbance of the lesions of the barrow by the scratching due to itching. But these are the lesions that we can see. Affection of webs of fingers by scratch marks, erythematous papular lesions, also webs of finger with papular lesions and scratch marks, erythematous lesions and scratch mark here in the webs of finger. This is a barrow on the side of the head, the hand, taking C shape. It's another barrow in the web of toes. This is a palm of a child, an infant. In infant, there is affection of palm and soles which are not affected in adults due to delicate skins in infants. The lesions are in the form of vesicles and bulli. These are ruptured bulli. Also, papules and scratch marks around the webs of fingers. Also, this is a barrow, which is usually not in most of cases. Scratch marks and papular lesions, crusted lesions around the umbilicus, affection of axilla, polymorphic lesions, also scratch marks and papular lesions, crusted lesions. This is a special form of scabies known as nodular scabies. After successful treatment of scabies, the patient may continue to itch. There are nodular lesions. Nodules mean palpable lesions with characteristic dimension of depth. The depth of lesion is equal or more than the superficial diameter of the lesion. Nodules, reddish brown in color, itchy, and they continue to itch after successful treatment of scabies. Usually occurs in infants and young children. It occurs on the axilla, around the umbilicus, in the groin, and it is due to allergic reaction to the previous Sarcoptes scabiei mite infection. Also, scratch marks and erythematous papules in the webs of fingers in cases of scabies, affection of the wrist joint, scratch marks, erythematous papules, and crusted lesions. Here, affection of webs of toes, scratch marks and papules, and vesicular bullous lesions on the sole of an infant. All these are pictures of scabies. Also, lesions around the umbilicus, scratch marks and crusted lesions. Here. So, clinical types of scabies. The pictures, previous pictures are of the human classic scabies. Animal scabies is due to infection by Sarcoptes scabiei var canis in cases of infection from dogs or cats, or scabies Sarcoptes scabiei var avium in cases of infection from the feathers of birds. In this case, the Sarcoptes scabiei mite of animals or of birds is qualified to live in feathers of birds or fur of animal. They cannot dig tunnels inside the horny layer of the skin like human Sarcoptes scabiei mite var hominis, which infect man. So, in cases of exposure to animals with animal scabies, there will be itching once the patient will exposed to these animals. So there is a short incubation period. It's a type of allergic reaction to insect bite once the patient is exposed to the insect. It is a self-limited disease because, as we said before, they will not dig tunnels, so they will not continue their life cycle and not reach to the nymph phase, which is the infectious phase. It will not be transmitted from man to man. The characteristic site affected in human type scabies are not affected here in animal scabies, like the webs of fingers and genitalia. And as we said before, there is no bar. Other types of scabies. Scabies in infants and young children is characterized by infection of palm and sole, which are not affected in adults. The lesions are in the form of vesicular bullous lesions. Scabies incognito, this is steroid modified scabies. The patient with scabies has received topical or systemic treatment with steroids. So at time you see the patient, the lesions will be exceeding the classic size of human scabies. As we say before, in classic scabies, the back is free and the buttocks only are affected. You can see in those patients, in cases of scabies incognito, that the lesions extend to affect all the back beside the buttocks. Scabies incline is the opposite of scabies incognito. Here the patient usually have frequent washing and frequent bathing. So at time you will see the patient, there will be very few numbers of lesions. Scabies in bedridden is like scabies, classic scabies, but the lesions are more at site of contact with bed. Venereal scabies is like also classic scabies, but the mode of transmission may be sexually transmitted, and in this case we must search for other sexually transmitted diseases like syphilis and gonorrhea. Norwegian scabies is a very severe form of scabies. It usually occurs in mentally retarded patients, patients with defective sensation, and in immune compromised patients, like patients with primary immune deficiency disease, or patients under treatment with corticosteroid or immune suppressive drugs. In those patients, there will be crusted lesions, extensive erythroderma, meaning erythema, and scaling covering more than 85% of body surface area. This patient may be exposed to severe illness due to increased capillary vascular permeability and decreased cardiac output, and there will be also disturbance of electrolyte and protein. So those patients need hospitalization and aggressive treatment of scabies. Also under the nails and the palm and sole are covered by crusted lesions. In nodular scabies, as we have seen before, this is an allergic condition to scabies. After successful treatment of scabies, the patient has erythematous nodules which are itchy, usually present in the axilla, around the umbilicus, and in the groin. Usually occurs in a This is nodular scabies, nodules in the axilla that continue to itch after successful treatment of scabies. Scabies in infancy, characterized by vesicles, vesicular lesions, visible accumulation of clear fluids within the epidermis of up to ½ centimeter in size, and bulli, which are larger than ½ centimeter, and these are ruptured bulli, eroded areas, and palm and sole of infant. Also the sole of infant with scabies, with bulli here. Also sole of infant with scabies, scabies in infancy. This is the crusted or Norwegian scabies, the severe form of scabies with erythroderma, erythema and scaling covering more than 85% of body surface area, with crusted lesions. You see the crust. These crusts are carrying thousands of mites, and the single patient may cause an epidemic of scabies. Also, the erythema with scaling and crusted lesions of crusted scabies. So the diagnosis of scabies must contain severe itching, which is more by night, and we have said why it is more by night. there will be more than one member affected because it's a highly contagious disease. The classic distribution, as we said before, the webs of fingers, flexor aspects of wrist joint, bilateral and symmetrical distribution of affection of the flexures of wrist, anterior fossa, axillary, the affection around the umbilicus. The back is free with the buttocks affected, medial aspects of side dorsal of feet, and besides these we will add the areola of the breast in female and the male genitalia. This is the classic distribution, which is a characteristic sign for scabies. But the lesions are polymorphic. We can see scratch marks, erythematous urticarial papules, excoriated papules, secondary bacterial infection in the form of pustules, crusted lesions, and so on. The diagnostic sign is a demonstration of mite. If we are lucky and can see one mite, we can moist the mite, the burrow. If we see the burrow, we will moist the burrow by potassium hydroxide 15% and scrape the lesions. We'll see the mite under microscope or its products like the eggs of mite, or directly by dermoscope on the burrow we can see the mite and its products inside the burrow. Complications of scabies bacterial infection. It is one of the features or the characteristic features of scabies to see crusted lesions or pustules which are due to secondary bacterial infection. But more severe bacterial infection may occur like boils, abscesses, cellulitis, and erysipelas. Eczema may be also features of scabies in cases of females, especially on the areola of the breast, but it may complicate scabies if the patient get contact dermatitis against the antiscabitic drugs. In this condition, the patient will complain of itching and burning sensation during application of the antiscabitic. Acrophobia is a psychiatric condition. The patient have a false feeling of being infected by insect inside his skin. Here the patient has no scabies, but he needs psychiatric consultation for these delusions or false beliefs. Differential diagnosis of scabies from other itchy conditions. Only scabies is described by polymorphic eruptions, but the other diseases, itchy diseases, have monomorphic picture. Like papilla urticaria, all the lesions will be like each other: erythematous, edematous, itchy papules. In cases of eczema, there is erythema, papullovesiculation, itching, oozing, and crustation. In cases of erythema multiforme, all the lesions are like each other. There may be iris lesion or the iris lesion with a darker point inside the erythematous macropapillary lesion of erythema multiforme, which may occur due to reaction to herpes simplex virus or other viruses, or a reaction to drug. So we'll have the target lesion or the iris lesions. The iris lesions will be visible inside the in the center of the erythematous macropapule of erythema multiforme. Treatment of scabies. We must give the patient instruction of disinfecting all the clothes, linens, and towels. and all the members of the family should be treated together to eradicate the infection. The antiscabitic, topical antiscabitic are like gamma benzene hexachloride 1% or benzyl benzoate 25%. These first two topical treatment are not suitable for infants or pregnant or lactating females because there may be toxic absorption of these substances, and that will cause epilepsy or other neurologic side effects. So in infants and in lactating or pregnant females, or in cases with secondary bacterial infection, we can use the other lines like sulfur ointment, 5% in children and 10% in adults, crotamidone 10%, or permethrin 5%. The application will be for the whole body except the head and the neck over night, and washing in the morning for 2 successive nights, and 4 successive nights in cases of sulfur on. Systemic treatment in the form of antihistamine for itching, antibiotic if there is secondary bacterial infection. We can give anti-scabitic systemic drug like ivermectin, and the dose is 6 milligram or 1 tablet per 15 kilogram body weight. In cases of crusted scabies, we must give the patient systemic anti-scabitic beside topical anti-scabitic beside salicylic acid 3% as a keratolytic, and the dose must be repeated after 1 week. Nodular scabies can be we can wait for a few months. If there is no resolution of the lesion, we can give intralesional injection of corticosteroid. If the patient has persistent itching after treatment, we can think of persistence of the hypersensitivity state, because all the lesions of scabies except the burrow are due to allergic reaction to the mite and its products. So we can wait for 2 weeks if there is persistence of itching, so we can think of unsuccessful treatment. We must repeat the instruction and repeat the antiscabitic. We may shift to other topical antiscabitic. The patient may have irritation to antiscabitic. In this case, he will complain of burning sensation during application of the antiscabitic. So shift to less sensitizing antiscabitic like the crotamidone 10%, which also have anti-pyruretic effect. Acarophobia, we may think of it if the patient continues to think of an insect inside his skin without any manifestations of scabies, and this patient needs a psychiatric consultation. Reinfection, this may be due to if the patient doesn't follow the instruction by treatment all the members of the family together, so he may be reinfected from other member of the family. So we must repeat the instruction and repeat the treatment for all the members of the family, and the disinfection of all linens and clothes. Pediculosis is a disease caused by louse. The types of pediculosis are pediculosis capitis affecting the scalp hair, pediculosis corporis. In this condition, the louse are present in the clothes and they visit the skin because this is a blood-sucking insect. It visits the skin, biting the skin, and return back to the clothes. This occurs usually in the neglected persons, like the street children and so on. The treatment will be the exchange of all these clothes by new clothes. This will be the treatment of cases of pediculosis corporis. In case of pediculosis pubis, in this condition, the louse is infecting the pubic hair. This may be sexually transmitted disease or may be infected by sharing towels, by sharing toilet seats and so on. Here, beside the pubic hair, it may extend towards the whole body hair or affecting the eyebrows even and eyelashes. This is pediculosis in a child. The mode of infection is via sharing of heads, combs, or in children they usually sharing their activities, and they contact their heads together. This may be a mode of infection, and a new mode of infection is the taking of selfie pictures in which the persons are in contact head to head for a long time. In cases of pediculosis, here the insect is of big size, about 4 millimeter in size. But they are few in number, so usually we cannot see the insect itself, but we will see these whitish concretes that are stuck to the hair shaft. These are the nets or the eggs of the louse. This is a common site of nets in the hair shafts of retroauricular area and the occipital area. There will be itching and scratching of the scalp. There may be secondary bacterial infection like Numbulus impetigo, crusted impetigo lesions. There may be also lymphadenopathy in severe cases, occipital lymphadenopathy. These are nets, this whitish concrete, and we can differentiate it from dandruff of seborrheic dermatitis. The dandruff will move away if you move it outside the hair shaft, but here we cannot move these whitish concretes on the hair shaft because they are stuck to the hair shaft. This is a hair in a patient with pediculosis. This is a hair shaft, and this is the net or the egg of louse, and this is a cement substance that cemented the egg to the hair shaft. In cases of pediculosis with impetigo, we must first treat the infection. Then after 1 week, after successful treatment of infection, we can use pediculicide. We cannot apply the pediculicide to raw areas of the skin because they are insecticides and have toxic effect. So the best antibacterial which we can use for treatment of impetigo with pediculosis is cotrimoxazole, because besides its antibacterial action, it has a pediculicidal action. We also give the patient the topical potassium permanganate as an antiseptic. The concentration is 1 over 8,000. Also, we give them sodium fusidate cream for 1 week. Then we will give them the pediculicides after treatment of impetigo. We may give gamma benzene hexachloride 1% shampoo application for half an hour, then washing, and ivermectin lotion 1% application overnight and washing in the morning. Also malasium application in the night and washing in the morning. All these pediculicides must be applied after 1 week, because they have effect only on the insect and they have no effect on the nets. So after 1 week there will be hatching of nets, and we can retreat the patient by anti-pediculosis drug to eradicate the infection. Urticaria is a skin disorder that is characterized by formation of wheals. Urticaria may present an example of allergic reaction, type 1 hypersensitivity reaction on exposure to allergen, which is maybe food or inhalant or insect bite or something like that. The antigen will cause the production of immunoglobulin E, and this immunoglobulin E will be fixed to its receptor on the surface of mast cells or basophils. On re-exposure to the allergens, the allergen will cause bridging between two adjacent particles of immunoglobulin E on the surface of the receptors. This will lead to degranulation of these granules inside the mast cells or basophil, and these granules are full of mediators. The most important is histamine. Histamine will cause vasodilatation and increased vascular permeability, leading to formation of wheals, angioedema, and the systemic manifestation of urticaria. Other types, non-allergic urticaria. In this condition, the patient may be exposed to, for example, radiocontrast media, salicylates, non-steroidal anti-inflammatory drug, ACE inhibitor. In certain patients, the exposure to these substances will cause direct mast cell degranulation with the release of the mediators and causing also urticarial lesions. So the cause of urticaria may be allergen, like food allergens, may be food stuff like eggs, strawberry, mango, and so on, in cases of acute urticaria. But in cases of chronic urticaria, usually it is due to the food additives more than the food stuff itself, like the preservatives and the color, taste, and odor developer. Drugs causing urticaria, the most important example is penicillin, of course, which may cause even anaphylactic shock in certain patients allergic to penicillin. Other drugs are like salicylates, non-steroidal anti-inflammatory drugs, and so on, may cause urticaria. Infections, in cases of acute urticaria, the most probable infection is upper respiratory tract streptococcal infections. In cases of chronic urticaria, more chronic infections are responsible for it, like Helicobacter pylori infection, chronic sinusitis, or chronic urinary tract infections. Inhalants like house dust and house dust mite. Collagen disease like systemic lupus erythematosus and rheumatoid arthritis may be presented by urticaria. Neoplasm like lymphoma and leukemia may be also presented by urticaria. Medical diseases, especially thyroid disease and liver and kidney diseases may be presented by urticarial lesions. Physical urticaria is caused by physical factors like pressure, heat, cold, and so on. Psychogenic urticaria is an important cause for urticaria, like anxiety and depression. After searching for all these causes, there is a group of patients which have no cause, and those were called idiopathic urticaria. But now more than 60% of those patients are found to be due to autoimmune cause of urticaria, in which there is autoantibodies directed to immunoglobulin E, or more commonly directed towards the IgE receptors. The characteristic lesion is wheal, and wheal is defined as evanescent. Evanescent means transient, that is, the individual lesion will not continue for more than 24 hours. The lesions patient may have the disease for more than years in cases of chronic urticaria, but if you ask him about an individual lesion, it will not have a duration for more than 24 hours. It may disappear from an area and reappear in another, but the individual lesion will not continue for 24 hours. It is usually itchy lesion, erythematous, edematous lesions of variable size, shape, and size. Here the patient has urticarial wheals, erythematous, edematous wheals here. On feeding, they will feed from the center, leaving some annular patterns like that. Besides the urticarial lesions, the wheals, the patient has also edema affecting the lips and eyelids. This is called angioedema. It is a lesion due to dermal or deep dermal or hypodermal edema of the areas with loose areolar connective tissue, like the eyelids, the lips, the genitalia. These edematous lesions are called angioedema. In cases of urticaria, 45% of patients of urticaria are presented with urticarial wheals only. 45% may be like this patient, presented with urticarial wheals and angioedema, and 10% may be presented by only angioedema. A child with multiple urticarial wheals, with some of them are showing annular pattern. Also urticarial lesions in a child, itchy, erythematous, edematous lesions. The individual lesion have the duration of less than 24 hours. Also urticarial lesions in child. General symptoms of urticaria: gastrointestinal symptoms due to edema of the mucosa of the gastrointestinal tract. It will be in the form of nausea, vomiting, and dysphagia. Affection of respiratory tracts may be hoarseness of voice, wheezing, dyspnea. Also cardiovascular system affection, due to vasodilation, extensive vasodilation. There may be hypertension. Special types of urticaria. Patient may have angioedema only in 10% of patients. Dermographism is known as writing on the skin by blunt pressure on the skin. The site you apply blunt pressure on the skin will give urticarial lesions will be formed within minutes. Cold urticaria due to exposure to cold, aquagenic urticaria due to exposure to water, whatever the temperature of water. Cholinergic urticaria occurs by asking the patient to do muscular exercise, or when the patient is exposed to stressful condition. It occurs with sweating. They are in the form of minute erythematous, edematous, itchy lesions. Solar urticaria due to exposure to sun. Contact urticaria is the most common example for contact urticaria is the exposure to jellyfish. The area of contact with jellyfish, there will be erythema and edema. Serum sickness is a disease may be caused by exposure to serum, antitannic serum, for example. The patient will complain of urticaria with that will be chronic, and arthritis, fever, and may be renal affection. This is a patient with angioedema only, without wheals. There are extensive edema of the eyelids and the lips. This is a dangerous sign because this edema, if extended to the larynx, it may cause suffocation. So rapid interference by adrenaline and other antihistamines must be directed to this patient. This cholinergic urticaria with minute erythematous, edematous papules surrounding the orifices of sweat ducts. Positive dermographies by applying blunt pressure to the skin. We draw this X shape by blunt pressure, so it will cause whealing at the site of pressure, like you see. Here is a synonym of urticarial wheals. So by blunt pressure we wrote on the skin that this HIV, it appears as urticarial wheals on the skin. Also these lines by blunt pressure are formed by erythema and edema after pressure on the skin. Pressure urticaria caused by pressure of clothes. Cold urticaria by application of a tube of ice. Erythema and edema started to occur under the area exposed to tube of ice. The course of urticaria, acute urticaria continues for hours or days. Chronic urticaria or urticaria with more than 6 weeks duration. This type of urticaria needs investigations to know the cause, if there is infection, if there is allergen causing urticaria and other systemic causes. Treatment of urticaria. The gold standard in treatment of any allergic condition is to know the cause and remove or stop the exposure to this cause. In cases of severe urticaria, we may use adrenaline. It is given as half centimeter subcutaneously every 30 minutes for 4 to 5 times until disappearance of urticaria wheals and angioedema. Antihistamines, we give it in the form of oral antihistamines in cases of moderate cases of urticaria. In severe cases, we can give it as intramuscular or intravenous injection. Calcium gluconate may cause stabilization of the mast cell, can be used as intravenous, slowly intravenous injection. Systemic steroids in the form of tablets in cases of moderate lesions, and in the form of intramuscular or intravenous injection in cases of severe cases. Topically, we can use 1% menthol in calamine lotion. Menthol will cause vasoconstriction of the blood vessel with resolution of the urticarial lesions. The last disease we'll talk about is papillary urticaria. This is hypersensitivity reaction to insect bites, usually to fleas or mosquito bites. It occurs usually in infants and children. The lesions in the form of itchy, erythematous, edematous papules with or without vesicles. The vesicle will appear in the center of the lesions. With itching, there may be secondary infection in the form of crusted lesions. The sites usually on the limbs, on the waist, with affection of the trunk, usually on the waist. This is acute papillary urticaria. The lesions are the form of erythematous, edematous papules with the center starting to form vesiculation, collection of visible clear fluid in the center of the lesion. It is itchy lesions. These are itchy lesions. Course of papillary urticaria. If the patient continues to stay in the area of insects, there may be a resolution of the lesion in most of patients, and this is a form of desensitization, or the patient begins to have no allergy towards the insect bite after that. In certain persons, usually the atopic persons, it will be transformed into the chronic form of papillary urticaria known as the prurigo of febra. Prurigo of febra. Prurigo of febra may be considered a type of atopic dermatitis. These are the criteria for diagnosis of atopic dermatitis. Three of these four criteria will diagnose atopic dermatitis if containing the first one. So pruritus or itching is present in cases of prurigo febra. So number one is present. But the typical morphology and distribution for age in cases of atopic dermatitis, the typical morphology and distribution in cases of children, which are the age group affected by prurigo febra, the lesions will be in the flexures of joints, like the antecubital fossa, the axilla, the sides of the neck, and so on, which are not affected here in prurigo febra. So this criteria is not present. But the lesions of prurigo febra have the course of chronic or chronically relapsing dermatitis. So if the patient have a personal history of other form of atopy, atopy is a hereditary disease characterized by formation of high IgE against common environmental allergen, and characterized by one or more of three diseases: bronchial asthma, allergic rhinitis, and atopic dermatitis. So if the patient have a personal history of other form of atopy like bronchial asthma or allergic rhinitis, or any one of his close relatives have any form of atopy like bronchial asthma, allergic rhinitis, or atopic dermatitis, or if the patient have high levels of IgE, we can consider this patient as a form of atopic dermatitis. This is a patient of prurigo febrile or chronic form of atopic dermatitis. There is itchy, shotty papules. These shotty papules are felt more than seen. Of large numbers, affecting the extensor surfaces of the extremities, upper and lower extremities. Besides these lesions, the patient started to have lichenified lesions. As you see, due to chronic itching, there are changes in the skin. There is the pigmentation, increased thickness of the skin, and exaggeration of skin markings. These are lichenified changes of the skin due to chronic itching. Besides the skin, the patient may have axillary and groin lymphadenopathy, inguinal lymphadenopathy also. Treatment of papular urticaria: we must treat or avoid exposure to the cause, which is insect bites. So the general method of treatment is disinfestation. We can use mosquito nets during sleep to avoid exposure to insecticides, or change the environment into the area without insects. The drugs we will use systemic antihistamine, oral antihistamines, and topically we can use steroids with antibiotics to guard against secondary bacterial infection. In severe cases which will not respond to topical treatment, we can give short courses of corticosteroids. We can read this. This is case which we have seen in case scenario and first part of the lecture. So beside the itching, which is more by night, on examination the patient has affection of the webs of finger by polymorphic eruption, erythematous papules, scratch marks. The rest of joints are affected, scratch marks also, and excoriated papules. The other sites that must be seen are the classic sites for affection with scabies. Beside the webs of fingers and the flexor aspect of wrist joints, you must see the antecubital foci, the axillae, around the umbilicus. You must see the buttocks, medial aspects of the thigh and dorsi of feet. In females, you must see the breast, the areola of the breast, and in male, we must see the male genitalia. The types of lesions: polymorphic lesions, as we see, erythematous, urticarial, papules, scratch marks, excoriated papules, secondary bacterial infection in the form of crusted lesions. So the diagnosis is scabies. These are the answers of the questions. So in this lecture we have talk about um, urticaria, papillary urticaria, scabies, and pediculosis. All these are itchy skin diseases. You can search for other itchy skin diseases and differentiate them from these four diseases. For further reading, you can look up for these references. Thank you for your attention.